Now let's turn to healthcare. It's hard for me to think of a better analogous situation to the mainframe computer, a centralized source of expertise that is extraordinarily complex and costly and not necessarily accessible to everyone, than the hospital. This is a business model built on an assumption that if you have a problem, you bring it here. We'll fix it. All the expertise is here. The problem with that is that this gold standard is not necessarily affordable and accessible, and it gets worse every day. And certainly not in areas of the world where you can't sustain one of these big behemoths, right? Instead, you're expected to travel long distances, or you go without, or at great expense. We try to build one and sustain it without really financials working out. But more importantly, you might live on the wrong side of the tracks. So even if there's a hospital in your own town, you may not have access to it. This is a picture of Rio de Janeiro, where the Olympics are going to be held, and I'm pretty sure they're not going to show pictures like this. But in the business world, we have a very polite term for people who can't access existing products and services. We call you non-consumers. And in healthcare, there are a lot of non-consumers of healthcare, right? There are the people who live far away, as I pointed out. There are the people who are simply too poor or are insured and can't access the healthcare system that we've constructed. Healthcare has centralized a lot of our roles and our functions into this business model of the general hospital. And as I said, it is that mainframe equivalent sitting at the center. And the question is, what's going to disrupt it? Well, in a way, we've already begun a lot of decentralization. The question is, can we do it more deliberately? It involves continuing to ask ourselves these questions. Are there things that we're doing in the general hospital today that perhaps should be done in an outpatient facility? There are a lot of things we've gradually transferred to outpatient settings over the years. The question is, can we do more of it very deliberately, knowing that technologies that enable this transfer of skills comes down the pipeline all the time? Are there things that we're doing in outpatient settings that we could do in an individual office, or better yet, in a kiosk, in a retail setting, or at the patient's work site? And ultimately, if we want to make healthcare as affordable as possible and as conveniently accessible as possible, we want to ask ourselves all the time, are there things that we're doing in these facilities today that we could potentially do in the patient's own home? Or better yet, make it mobile so it goes wherever the patient goes. But it's not just about transferring the venues, right? It's also about transferring skills. So whereas the general hospital is dependent upon a lot of expensive experts trying to work together, the question is, can we transfer some of their skills, what's embedded in their brains, put it into a piece of software, a device, or a training program, so that we could transfer some of those skills to an individual practitioner? And not just a physician, but perhaps, as we heard in previous talks, putting those skills into the hands of a nurse practitioner, a physician assistant, a pharmacist, or really a whole slew of allied healthcare professionals that are tremendously underutilized over time, as we could enable them and equip them with technologies to empower them to do more and more. But ultimately, if we're to reach that outermost ring of customers, those non-consumers of healthcare, we need to put more and more power in the hands of consumers using technologies that can allow this to be done safely. That's the only way we can transfer our healthcare system into a setting that is affordable and accessible to everyone. And as I said before, disruption is not a one-time event. We can use it as a crystal ball to understand what's coming next. Well, if we get it to a point where a protocol is rigid enough, well understood enough, that we could say it doesn't really require the MD to manage this process anymore, could we in fact hand over this work to a nurse practitioner or a pharmacist or somebody else that can do this safely? Or better yet, and especially if you live in a part of the world like Southeast Asia where H. pylori is endemic, your only hope is not to funnel everybody through a healthcare professional, but to try to get these diagnostic tests into the hands of patients where they can be easily interpreted and make the drugs behind the counter or even over the counter if you can do that safely, so that you can really treat this disease effectively as a public health problem. So last message is to the doctors. As I pointed out, we can often stand in the way if we remain highly critical of all of these disruptive forces and say, that just can't replace me. You know, it can't replace all of my years of experience and education. I'm the best provider for your care. Or we can say, well, I want to be the best provider for your care, but really where I'm most needed. All the other stuff, as long as that person can be a safe and effective replacement, I want that to happen as well. We have a lot of goodwill built among the public. if we continue to stand in the way of things that can actually benefit our patients, we're not going to have the same type of standing in the future. And medical doctors have almost unparalleled levels of trust in terms of how we manage healthcare for our patients. And again, we want to take advantage of this goodwill and help make sure that healthcare is disrupted in a good way. Disruption is not a bad word. It is good for our patients. It happens in all of these other industries. It's been slow in coming in healthcare, but I think, again, with all of your help and support, we can make it happen. Thanks very much.